To understand the treatment of Parkinson's disease, we should first understand how dopamine is produced. Say this is a presynaptic neuron and this is postsynaptic neuron. Dopa is the precursor molecule of dopamine. It produced from the amino acid tyrosine. The dopa decarboxylase enzyme acts on dopa and produces dopamine. Then dopamine is released from the presynaptic neuron and then acts on dopamine receptor present on the postsynaptic neuron. As all of us know, in Parkinson's disease, the amount of dopamine is decreased. So, all we have to do is to increase the amount of dopamine for treatment of Parkinson's disease. We can do this by introducing dopamine precursors exogenously. We use levodopa. In fact, levodopa is the drug of choice for Parkinson's disease. Levodopa in our body produce dopamine with the help of the enzyme dopa decarboxylase. Now, you must be thinking why I am giving dopamine precursors. Why not dopamine directly? This is because dopamine is a polar compound and it cannot cross blood-brain barrier. Now, levodopa is also a polar compound, but it has a aromatic amino acid transporter to transport it across the blood-brain barrier. That's why we use levodopa. Just now I told you that levodopa will produce dopamine in our body with the help of the enzyme dopa decarboxylase. Now, the dopa decarboxylase enzyme is present throughout our body, and the major chunk of dopamine is metabolized outside the CNS, which not only decreases the central effect but also increases dopamine related peripheral side effects. Carbidopa is a compound that inhibits the dopa decarboxylase enzyme, and since these are lipid insoluble, they do not cross the blood brain barrier. For this reason, levodopa is always combined with carbidopa so that maximum levodopa moves to CNS. Carbidopa also inhibits the peripheral side effects of dopamine by inhibiting the metabolism of levodopa. Vitamin B6 is a cofactor for dopa decarboxylase enzyme and can increase the peripheral metabolism of levodopa. That's why vitamin B6 is contraindicated with levodopa therapy. Vitamin B6 is contraindicated in levodopa therapy. Now, coming to a very important concept known as on-off phenomenon. It is another drawback that develops because of progressive nature of the disease. Suppose a patient with Parkinson's disease has 60% dopamine in his body, rest 40% has degenerated. Now, we should supply 40% exogenous dopamine to this patient. Normally, the patients are advised to follow up at every 3 months. Now, suppose there is a patient who is coming to you after 8 months. Till that time, his disease has progressed. Now he has 50% endogenous dopamine. Generally, we prescribed levodopa 3 times a day. But the exogenous dopamine he was taking is still 40%. So there is 10% dopamine deficiency in his body. When the patient takes the first dose of dopamine, he remains asymptomatic for several hours after the first dose. Then, when the effect of medicine goes down, he becomes symptomatic. After that, he takes the second dose of the medicine and then again he becomes asymptomatic. And when the effect of medicine goes down, again he becomes symptomatic. So, the reason is the exogenous dopamine we are giving to the patient is not enough. So, this asymptomatic period is called on period, and the symptomatic period is called off period, and the phenomenon is called on off phenomenon. Now, coming to the side effects of levodopa, which is basically due to increased amount of dopamine. The peripheral side effects are nausea, vomiting. It is due to stimulation of D2 receptor in the chemoreceptor trigger zone, and arrhythmia and postural hypotension due to stimulation of D2 receptor present in the kidney due to increased amount of diuresis. And the central side effects are psychosis due to stimulation of D2 receptor present in the limbic system, and dyskinesia or hyperkinesia due to overstimulation of the D2 receptor in nigrostriatal pathway. So, this was all about levodopa. Now, let's see the other treatment options of Parkinson's disease. Dopamine is metabolized in the synapse by two enzymes, catechol O methyltransferase and monoamine oxidase B. If we inhibit these two enzymes, we can increase the amount of dopamine in the synapse. Now let's talk about the Compt inhibitor. The drugs are tolcapone and entacapone. Now if levodopa is combined with Compt inhibitors, the half-life of levodopa increases because these drugs inhibit the peripheral metabolism of levodopa. Catechol O methyltransferase enzymes are also present peripherally and they inhibit the metabolism of levodopa in liver. Tolcapone causes hepatotoxicity. That's why it is less preferred, though it inhibits both the central and peripheral COMT. On the other hand, entacapone cannot cross the blood-brain barrier. It only inhibits the peripheral metabolism of levodopa in liver, but it is safer than tolcapone. Now, if we use levodopa, carbidopa and entacapone combination in a patient, in the first step we are blocking the peripheral metabolism of levodopa by inhibiting the dopa decarboxylase enzyme. And in the second step, we are blocking the peripheral metabolism of levodopa in liver by blocking the hepatic COMT with entacapone. But we don't use this levodopa, carbidopa and entacapone combination in a patient because there will be excessive amount of dopamine in CNS. And if There is so much of dopamine in CNS, there will be excessive amount of side effects related to dopamine. It will make the patient dyskinetic. Now, in situation where we have to use these three drugs, we should reduce the dose of levodopa. Now, the next drug is Mao-B Inhibitor. The drugs under Mao-B inhibitors are selegiline and rasagiline. These drugs are commonly used in young onset Parkinson's disease and for the treatment of on off phenomenon. They also prevent the neurodegeneration in Parkinson's disease as they have antioxidant effect. Now, there is another way we can stimulate the effect of dopamine is by stimulating the D2 receptors. For this, we have D2 receptor agonist. The D2 receptors are again divided into two groups, ergot agonist and non-ergot agonist. The ergot agonists are bromocriptine, cabergoline, and pergolide, but they are rarely used because of their side effects. Bromocriptine causes peripheral vasoconstriction, and cabergoline and pergolide cause cardiac valve fibrosis. Non-ergot agonists are longer acting than levodopa. They have lesser chance of on-off phenomenon. They are used either as monotherapy or used along with levodopa. They are also drug of choice for restless leg syndrome. The drugs are pramipexole, ropinirole, and rotigotine. The side effects of these drugs are peripheral edema and impulse control disorder. Now, I have forgot to mention about a drug under D2 agonist is apomorphine. If nothing is effective to treat on-off phenomenon like Compt Mao-B inhibitor, we use apomorphine as last hope. That's why it is used as rescue therapy for on-off phenomenon. Now, coming to the last two or three drugs that are used in Parkinsonism are amantadine. It has basically anticholinergic effect. It also increases dopamine release and it is used in mild Parkinson's disease. The anticholinergic drugs that are used in Parkinsonism are benztropine, bipyridine. They are the drug of choice for drug induced Parkinson's disease with typical antipsychotics like chlorpromazine and haloperidol.